Before we actually talk about specific pathologies of the kidneys, I thought it might be helpful to review how pathology can actually affect the functions of the kidneys themselves. So what we're going to do in this short videotape, or audio tape really, is talk about how pathology alters the functions of the nephrons and then the homeostatic functions of the kidneys. Because of those altered functions, then, we can talk about very broadly some of the multi-system effects, especially of chronic kidney disease, although some of these effects would certainly also be identified and manifested in an acute kidney injury or disease as well. So just as a quick review, remember this is the nephron. It's estimated there are about 1 million nephrons in each kidney. No, I don't know who counted them. But there's about 1 million in each kidney. So as a result, then, we know that the kidneys are very redundant structures. That's a good thing because we know that we can live with one kidney, a partial kidney, whatever. So remember your basic anatomy when you think about that. And so we have a glomerulus, which is a knot of high pressure, is a high pressure capillary bed. Then you also have the tubular system. In the tubular system, you have the proximal convoluted tubule. That then enters the loop of Henle. There is a descending as well as ascending limb of the loop of Henle. That then goes to the distal convoluted tubule and the collecting duct, or the collecting tubule. And you'll see that several distal convoluted tubules actually come in and enter a single collecting tubule. Remember that once the urine leaves the collecting tubule or the collecting duct, it is what it is. There isn't any additional change of the urine itself. So one of the most important structures is the glomerulus. Recall from your anatomy that the glomerulus, which is the first part of the nephron, is entered as well as exited by an arteriole. You enter by the afferent arteriole and you exit through the efferent arteriole. So then if you increase or decrease the resistance of either one of these arterioles, it's going to make a difference in the glomerular filtration rate and what we're able to do within that glomerulus. You can also see that there is a supporting structure that is continuous with the proximal convoluted tubule, and that is Bowman's capsule. In between the glomerular cells here and the capsule itself, you can see there is a space, and that Bowman space is very important, and we're going to talk about the importance of that space in just a little bit. Reminder, there's your efferent arteriole, and this whole thing sort of twists back on itself. It's not all lined out nice and pretty the way we always see it in textbooks. So let's talk about this in a little bit more detail when we talk about altered nephron functions. So the first thing we want to think and remember about are the functions of the nephron. The functions are filtration, reabsorption, secretion, and excretion. The glomerulus is responsible for filtration. So if something doesn't get filtered at the glomerulus, it cannot be reabsorbed and it cannot be excreted. Now, it still can be secreted, but it cannot be reabsorbed nor excreted. We'll talk specifically about that because the functions of reabsorption, secretion, and excretion are what the tubules do. So let's go back up to the top and talk about these as a beginning. When we think about filtration through the glomerulus, remember that is a semi-permeable membrane. And when we talk about the filtration and a semi-permeable membrane, what gets filtered out across that membrane depends on a number of different things. One of the things is the size of the molecule. Protein, very big molecule. That's why you don't expect to see protein in the urine. The electrical charge is also important. So if the electrical charge of the substance is the same as that of the membrane itself, it would be repelled as opposed to be able to cross over. So when we think about filtration in the glomerulus, that's why we call it the glomerular filtration rate. And the glomerular filtration rate is something that we measure through the creatinine clearance. Once again, stay tuned. We're going to talk about that. So with filtration, there are three major forces that are very, very important in order to have a positive filtration through the glomerulus. And these are autoregulation of blood flow, the pressure in that space, Bowman space, as well as the plasma oncotic pressure. Remember that what we're talking about with autoregulation is the ability of the afferent and the efferent arteriole to keep a positive pressure within the glomerular capillary bed that favors filtration. So in order to filter across that basement membrane, the pressure on the arterial side, which is in the artery itself, has to be greater than the pressure in Bowman space. That's a net filtration pressure. Anytime that pressure in Bowman space exceeds the pressure that's actually in the artery itself, filtration will be either stopped or certainly less effective. The other important concept on the filtration side is the plasma oncotic pressure. Once again, there has to be a high enough plasma oncotic pressure within the vessel, that arterial bed, to overcome the pressure in Bowman space to foster a positive filtration pressure. Because what's going to happen is, as we filter across that semipermeable membrane, an ultrafiltrate is formed. That ultrafiltrate is essentially urine, but it's primary urine, and it has a lot of stuff in it that never ends up in the urine, or very little of what ends up in the urine. And so think about Bowman space, because as you saw it in the anatomy, that space is continuous with the proximal convoluted tubule. So in order for something to be in the urine, it has to enter Bowman space. Well, for the most part, has to enter Bowman space. So what happens then is we physiologically make this ultrafiltrate, and we make about 1,200 cc's per minute. Isn't that huge? So imagine making 1,200 cc's of primary urine every minute. Well, you have to be able to change that in order to decrease that to a manageable urine output. And that's what the tubules are responsible for. The tubules are responsible for the reabsorption, the secretion, and the excretion of this within this ultrafiltrate, so that we end up with 0.5 cc's per kilo per hour of urine. So that's what has to happen. The glomerular filtration rate, which is happening at the glomerulus, is very important for us to determine what's going to happen in the tubules. So let's talk then a little bit more about the tubules. With the tubules, there are three important functions: reabsorption, secretion, and excretion. Reabsorption is when the tubules, when the blood system actually takes back substances that are in that ultrafiltrate. Once again, if you think about anatomy, we talked about the afferent arteriole and the efferent arteriole. There are small branches of arteries that come off the efferent arterioles that go into into the peritubular capillaries, and that's what supplies the tubules. And these peritubular capillaries are wound all around those tubular structures. That's what allows the body to reabsorb substances from this ultrafiltrate. Remember, the ultrafiltrate is inside the tubular lumen, and so what those peritubular capillaries do is they take back some of the substances that are actually in that ultrafiltrate. So as a result then, we are going to reabsorb a lot of substances, and the vast majority of our reabsorption actually occurs in that proximal convoluted tubule, that very first part of the nephron. The other piece that we want to be aware of is that many substances have a tubular maximum. A tubular maximum means that there's a point at which the tubule cannot allow any additional reabsorption into the peritubular capillaries. The peritubular capillaries can't take up any more. Remember in the pretest, and we talked about glucose, and we talked about the tubular maximum? As we talked about, once the blood sugar reaches about 180 milligrams per deciliter, the tubules have a lot of trouble reabsorbing any additional glucose. So that's why you start seeing glucose in the urine as that blood sugar continues to rise, because the tubules have reached their maximum ability to reabsorb the substance. We also talked about this with multiple myeloma, with the light chains. Most light chains that are broken down are reabsorbed in the proximal convoluted tubule. However, when there is massive breakdown of light chains, the tubules can't reabsorb anymore. The tubular arteries, capillaries can't reabsorb anymore back into the circulation, and so as a result they end up in the urine. Secretion is the movement of substances from the circulation into the lumen of the tubular system. So with secretion, the things we think about, again, fairly selective, and if we're moving substances from the circulation into the lumen, the reason we're doing that is because we want to get rid of them. Great example of that is hydrogen ion and bicarbonate. So when someone is acidotic, what they want the body to do, or they want the tubules to do, is secrete more hydrogen ion into the tubular lumen so it can then be excreted. And then, of course, excretion is what we're going to get rid of, what's actually going to flow out and is going to end up in the collecting ducts, and that's what is going to end up in our urine. So that becomes very important. So you've got big mechanisms here. So then think about if you have, when we talk about glomerular pathologies, we're going to look at filtration, aren't we? If we look at tubular pathologies, we're going to look at reabsorption, secretion, and excretion. And all of those are going to help us when we talk about pathologies. The last thing to remember is that, well, actually two last things. One is that there are two different types of nephrons. There are cortical nephrons and there are juxtamedullary nephrons. The vast majority of nephrons are cortical nephrons, and that means that they have short loops of Henle. That's like 85% of them, and that's where we do a lot of our basic work. However, about 15% of our nephrons have very long loops of Henle that dip further down into the medulla of the kidney structures. And these juxtamedullary nephrons are the ones that contain the vasa recta. Now, why do we care about the vasa recta and the juxtamedullary nephrons? Yes. Renin-angiotensin-aldosterone mechanism. When the body is stressed and we need to assure that we have good blood pressure control, or we need to hold back more fluid, we physiologically will shunt blood to these juxtamedullary nephrons, because that's where the renin-angiotensin-aldosterone system is situated, within the vasa recta. The last thing is, remember your hormones. Renin, angiotensin, aldosterone, ANP, and ADH. All aldosterone, ANP, and ADH all function within that tubular mechanism. Hope that made sense. If you have any questions, we can go over them in class. So as a review, one more time, filtration is a glomerular function. Semipermeable membrane, you have to have a positive net filtration pressure, more pressure in the vascular side than in the Bowman's capsule side. Bowman's space side. Bowman's space is continuous with the tubular mechanism. Within the tubular mechanism, we have reabsorption, so we're taking things back from the tubules back into the circulation, but the circulation can also secrete substances that they want to get rid of into the tubular lumen. Once all of that happens, and different things will move in different parts of the lumen, then it has to be excreted. And remember that excretion, once you exit the collecting duct or the collecting tubule, the urine is what it is. It isn't going to change anymore. So what would the consequences of altered function be? First off, remember that we have to change that ultrafiltrate to urine output. And I desperately want you to remember that 30 cc's an hour is very old thinking. So when we think about urine output, we think about, in an adult, 0.5 cc's per kilo per hour as our minimum, because that's what it's going to take to filter and then also excrete the solute load. If we have altered function in the glomerulus, we can't filter, and if we have tubular dysfunction, the ability to concentrate as well as dilute the urine is going to be affected. So then if we take a step back from that and we think about everything that the kidneys do, we've only talked about the excretory functions and the secretory functions, but there are so many things that the kidneys do that can lead to pathophysiologic alterations in other body systems. So let's just go through those. Metabolic waste removal, that makes sense. Urea, nitrogen, those are big metabolic waste products, primarily from the breakdown of protein waste products. Certainly it makes sense that we would be doing fluid and electrolyte balance. We have to either get rid of or keep or maintain or keep more water. And then again, that tubular function, secretion and absorption. With acid-base balance, we can reabsorb hydrogen ion and bicarb. We can secrete hydrogen and bicarbonate, and we can also make buffer by combining hydrogen with a bicarbonate, or add a phosphate and make phosphate instead of PO3. We make PO4. So our acid-base balance is important. Hormone secretion, we talked about that in terms of renin-angiotensin-aldosterone and the other fluid balance hormones, but we know that the kidneys also make erythropoietin. Most of our erythropoietin, 90%, comes from the kidneys, about 10% comes from our liver. And then we also know that we need dehydroxycalciferol, which helps us with the activation of vitamin D, and we need that for healthy bone metabolism. Blood pressure regulation, I think we've talked about that. That makes sense, not only on the volume side, but also on the renin-angiotensin-aldosterone side. Erythropoiesis, again, remember, hormone, erythropoietin. Vitamin D activation and metabolism, that is going to have impact on dehydroxycalciferol, therefore bone metabolism. Also, when the kidneys do not work well, we tend to hold on to more phosphorus, and that can lead to bone disease. And last but not least, prostaglandin synthesis. In the kidneys, prostaglandins are local vasodilators, and so we want to protect that local vasodilating effect. As we think then about how we might, some of the ways that this pathology in the kidneys might manifest, we want to think about, well, how would we know that? And one of the ways is to look at the urine itself. There's a really good reason why doing a urinalysis is called a poor man's biopsy, because you can tell a lot from looking at a urinalysis and what is or is not in the urine. So in pathophysiology, we're going to focus in on things that really shouldn't be there. So intact red cells, generally what we're looking at is it may be a glomerular disorder. It may be, if it's coming from the kidneys, we're thinking about intact red cells and a glomerular function for the most part. If this isn't kidney, we think about it in terms of a bladder issue, because bladder cancer presents as red cells in the urine. With white blood cells, that's the one we probably know the best, because white blood cells in the urine, we think about a urinary tract infection. Because remember, this renal pathophysiology, we're talking mostly about renal, but we also have to talk a little bit about urology, which we will do as we talk about disorders. Now, casts are very interesting. Casts are literally cellular debris. These are cast off cells from the epithelial membrane. So that you can have tubular epithelial casts, you can have glomerular epithelial casts, you can have red blood cell casts, white blood cell casts, which tells you that they have been broken down partially. Now, broad waxy casts are very important because broad waxy casts are actually, they're like little bricks that actually conform to the size and the shape of the tubules. And this is a sign of stasis of flow within the tubules. This is generally a very poor sign because it tells you that there isn't much flow through that tubular lumen and is usually a late sign of chronic kidney disease. Remember that the other thing that we think about in terms of the urine is we want to think about how concentrated or dilute the urine might be. And we do that on a urinalysis by looking at the specific gravity. The specific gravity of water is 1, therefore very dilute. So when you look at urine specific gravity, the closer the specific gravity is to 1, the more dilute the urine is. The higher that specific gravity, the more junk, the more like debris, the more concentrated the urine is, and so we would be very concerned about that. If we look at urine-specific gravity along with an elevated creatinine level in the serum, we need to look for a tubular issue because the tubules are struggling. So let's talk about some of the serum studies that we might be able to use. One of the things that we use is the creatinine clearance. Now, the creatinine clearance is the amount of creatinine that is cleared by the kidneys. So you're always looking at the relationship of what's in the blood versus what shows up in the urine. Now, we use creatinine because creatinine is freely filtered by the glomerulus and minimally reabsorbed by the tubular system. Urea nitrogen gets, because it breaks down differently, has a lot more things that can affect the function and actually its reabsorption or its secretion. So that's why we use creatinine. And the amount of creatinine varies by gender and by age. When we measure the creatinine clearance, we're actually measuring a reflection of the glomerular filtration rate. Now, it's not perfect because remember, this is a functional parameter. And so because we're looking at how well the kidneys are able to function, able to clear the creatinine from the blood, we actually on a creatinine clearance can overestimate a true glomerular filtration rate by 10 to 15%. Well, why does it do that? Because the tubules have the ability to filter a higher solute load when they are under stress. And it also takes time then for this creatinine to actually increase. One of the things we use here is that creatinine clearance. We use it also to estimate, that's that little e, to estimate the glomerular filtration rate. An estimated GFR uses serum studies in stable kidney function, but is not useful in acute kidney injury because in acute kidney injury things are changing too rapidly. But an estimated GFR in chronic kidney disease is very, very helpful in determining the progression of a chronic pathology. Now, the last thing that I put on here is the significance of very small early changes when that serum creatinine is changing. And what I mean by that is a 1 milligram per deciliter change represents a different damage and decrease in function depending on where that change occurs. So let's say the creatinine goes up from 1 to 2. That can represent a loss of about 50% of kidney function. However, when the creatinine goes from 3 to 4, they may only have lost another 10% simply because they didn't have as much reserve anymore. One of the substances that we are using more frequently instead of creatinine is cystatin C. Cystatin C is a low molecular weight protein. Find it in most tissues, just as creatinine is found in most muscles, and it is removed by the kidneys. We are using this again for a functional marker of kidney function. One of the reasons we started using cystatin C is that one of the things, remember we talked about a sudden change in GFR frequently doesn't get followed immediately by that change in the serum creatinine. So this is more sensitive than the creatinine level itself. In addition, cystatin C doesn't have as many things that affect it, like infection, diet, and so on. And again, just like the creatinine clearance, the cystatin C and the creatinine, like the creatinine level, the cystatin C, the elevated level actually correlates a bit better with a decrease in the GFR. In our national guidelines for the diagnosis and evaluation of chronic kidney disease, we recommend strongly that the cystatin C be used in our estimations of glomerular filtration rate rather than the creatinine level. Now, you know my love of cellular biomarkers, so I had to bring this to you as well. As we talked about, cystatin and creatinine are functional biomarkers, and of course certainly urine output is a functional biomarker as well. In the last 5 to 10 years, there has been an explosion not only in the identification but also the use of cellular biomarkers. And what I've done here is listed the ones that have more data behind them and that we know a little bit more about. The one that we've had around the longest is NGAL, or neutrophil gelatinase associated lipocalin. This is a cellular biomarker that we can find in the plasma as well as in the urine. This has been used for about 10 years, primarily in Europe, and occasionally we see it in the US, but it hasn't really caught on. No, I don't know why, because it is very, very helpful in helping us predict especially acute kidney injury, and that's really where these cellular biomarkers come in. KIM1 is kidney injury molecule 1. I love it that they made this one easy for us. This is found in the urine. IL-18 is an interleukin that we can track in the urine. And then the next two are very interesting, IGF and TIMP. IGF is insulin-like growth factor, and this is a binding protein that is found in the urine. TIM is tissue inhibitor of metalloproteinases. These two take very small aliquots of urine, and there's actually a bedside assessment, a little bedside machine called NephroCheck. You put a small aliquot of urine in it, and then in a few minutes you can determine the likelihood that someone is at risk to develop acute kidney injury. Now, all of these cellular biomarkers that we talked about, NCAL, KIM1, IL-18, and the IGF and TIMP are all used in the diagnosis of acute kidney injury. Urokinase type plasminogen activator receptor, however, has been used as a predictor of the development of chronic kidney disease. Urokinase type plasminogen activator receptor is expressed by the podocytes, and the podocytes are part of our glomerular system. And what they've identified is this activator receptor actually induces dysfunction within the glomerulus and within the nephron. Research has identified that this activator receptor increases before the GFR begins to drop. So when this is elevated, they've identified that individuals with this elevated activator receptor are 3 times more likely to develop chronic kidney disease within 5 years. This is something that I think we're going to learn more and more and more about. I hope this has been helpful. Kidneys can feel very challenging and very difficult, so I hope this introduction will help us move forward as we talk about the pathologies. But remember filtration, reabsorption, secretion, and excretion. Filtration is a glomerular function. If something isn't filtered, it cannot be reabsorbed, it cannot be excreted. But remember that the tubules, that's where the reabsorption and the excretion occurs, but also secretion. Remember those paratubular capillaries. Each process supports homeostasis. So as we think and we talk about pathology, I want you to think about the process that's affected, and then we can then take that to the homeostatic functions that are being affected, and that will help us think through the pathology. Let me know if you have questions. Thanks for your attention.